I want to talk to you about knee arthroscopy. We have gone over your history and physical and gone over the imaging and have decided that arthroscopy is appropriate for you. Knee arthroscopy is a minimally invasive procedure. We use a long, thin arthroscope, which is an instrument that is passed through a small portal. The portal is about 1 centimeter and allows us to see inside the joint. The arthroscope is attached to a video camera. The video camera is attached to a video monitor, and there are large overhead monitors that allow everyone in the room to be able to see what's going on in your knee. In fact, you can watch what's going on as well if you'd like. In order to do that, we would use a spinal anesthetic so that you're numb from the waist down, and then you can watch the screen to see what's going on. You're welcome to watch. In fact, I encourage you to watch, and I can walk you through the findings, the pathology, and the treatment as I'm operating, and you're watching the screen. You're not actually watching your knee, but you're watching the monitor, and you can see what's going on in your knee. This can be helpful so that you better understand the procedure afterwards. If you decide that you would prefer to have a light general anesthetic, we can do your anesthesia without actually passing a endotracheal tube down, but just an airway. And it is a little bit quicker with a light general, and you're at hospital for a shorter period of time because you don't have to wait for the spinal to wear off, but you don't have the advantage of being able to watch your surgery. In order to allow everyone to see the pathology, I take a lot of photographs during the procedure so that if you do decide to have a general anesthetic, you'll still have the photographs to be able to identify and see what the findings were. If you have a spinal anesthetic, the photographs will help remind you what you saw at the time of surgery. Either way, you'll be able to see the pathology and see what we did to treat the pathology. Now, the procedure itself takes about an hour. I typically use 3 portals. If you look at the knee, anteromedial, anterolateral, and superolateral, each of the portals about 1 centimeter in size. One of them is used for the arthroscope, one is used for instrumentation, and the third is used for outflow. The outflow is to maintain clarity of our field of view. And we do put a tourniquet on the upper thigh as high as we can get it, keeping room for the prepping and draping. And we end up using the tourniquet in a fairly small percentage of the time, but if there is blood that obscures our view, we will pop the tourniquet up, which helps to clear the view so that we can see exactly what's going on in your knee. Now, the 3 portals can be used interchangeably, so that although we may start with the arthroscope in the anterolateral portal, it will be moved to anteromedial and superolateral. We already have the portals in place, so there's no additional morbidity, and we're able to see the joint from all 3 perspectives so that we can see all compartments of the joint. The medial compartment on the inner side, the lateral compartment on the outer side, the patellofemoral compartment, as well as the gutters through to the back and the intercondylar notch. So all parts of the knee are well visualized with those portals. We then use small instruments to do the work. Rather than having to open the joint, make an open arthrotomy for exposure, the arthroscope allows us to see, and in fact we can see better with the arthroscope than we can see with an open procedure because the arthroscope provides for magnification. In fact, when you're watching the screen and you see that small instrument come in, it looks quite large because of magnification, but they're actually small instruments, typically 3.5 millimeters in size. Most of the procedures can be done completely arthroscopically, whether that's meniscal repair, loose body removal, chondral debridement, treatment of synovial lesions, and even treatment of ligament injuries. Some procedures require arthroscopic assisted, which is a combination of both open and arthroscopic surgery. for example, an anterior cruciate ligament reconstruction is arthroscopic assisted, where the intra-articular work is arthroscopic, but there is a small extra-articular incision. The arthroscopic procedures that is most common is for the treatment of meniscal tears, whether it be medial or lateral. Medial is slightly more common than lateral, but we see this very frequently. And this is treated either by meniscal repair or by partial meniscectomy. Partial meniscectomy implies trimming of the torn part of the meniscus. Now, the meniscus has function, and that function is to help distribute the forces across the joint. It helps to protect the articular cartilage. It has some small secondary stabilizing effect, and there is an effect on nutrition. But the meniscus, therefore, has function. We do try and preserve it if it's reparable. Unfortunately, the reason the meniscus tends not to heal is because of its poor blood supply. Typically, a meniscal tear instability combined with the poor blood supply result in persistent symptoms and failure of healing, which lead to the need for arthroscopic intervention. At surgery, we assess the tear pattern. If the tear is in the zone that is well vascularized, which is at the peripheral third of the meniscus, these are the red on red or the white on red tears, then it is considered reparable. But there are many factors that go into the decision on reparability of a meniscal tear. The vascularity is the number one consideration, but the tear pattern, the tear location, the age of the patient, the time since the injury, associated pathologies, associated instability, arthritic change, as well as patient's expectations, patient physical demands on the joint, can all play a role in the decision. But typically, if it's reparable, we repair it. And if the tear is in the avascular portion of the meniscus, the inner free margin has no blood supply and has very poor healing potential, it doesn't make sense to repair a tear that has poor healing potential and a high failure rate, because you would go through repair and then ultimately find that it failed to heal, and you would be back and have to go and undergo a further operation. So in the setting of a meniscal tear that has poor healing potential, you're better off to treat it with an arthroscopic partial meniscectomy, which is a trimming of the torn part of the meniscus. Now, when we're sitting on the fence and it's a borderline call, we tend to repair the meniscus, recognizing that we're preserving meniscal function. But if it does go on and fails to heal, we would have to come back for a second operation to remove the failed meniscal tear healing. Now, there is a difference in the post-operative rehabilitation between repair and trim. With a repair, we need to protect the repair, and because the blood supply is tenuous, it can be slow healing. Healing is around 15% in a month, and so it gradually heals over time, but the first 6 weeks is the most important phase. And during that time, we use a brace, and that brace is locked in extension, so that weight-bearing forces across the joint are axial, but we don't have a shear with weight bearing through range of motion. The knee's locked in extension. So you're on crutches for the first 3 to 4 weeks. You're gradually increasing weight bearing, so you do get the benefit of weight bearing, but locked in extension. We do remove the brace to work on knee range of motion exercise in order to avoid stiffness, but it's gentle motion without force. And then the brace is applied for ambulation. We also do some strengthening with the knee locked in extension, so you can do a straight leg raise, which allows you to work on quad strength, but again, we're not strengthening through range of motion, which can result in a shear force on that meniscal repair. So we do weight bearing, we do motion, and we do strengthening, but we don't do them together. The weight bearing is locked in extension, the motion is removing the brace for gentle motion, and the strengthening is isometric strengthening through straight leg raise exercise. And your physical therapist will guide you through this process in the setting of meniscal repair. And the brace is worn for 6 weeks, followed by further rehabilitation. Now, in the setting of a partial meniscectomy or meniscal trim, we don't have any meniscal healing to occur, so the recovery is substantially faster. We still have portal healing, and there's still the washout effect of the normal lubricants of the joint. When we do an arthroscopy, we're looking through a saline environment, and it does wash out the lubricants, and it takes 3 or 4 weeks to reestablish the normal lubricating value of the fluid. So during that time, it's important to not to overdo it. If you overdo it, you pay for it with pain and swelling. But there'll be a gradual increase in activity during that time. Typically, after an arthroscopic partial meniscectomy, you're on crutches for 2 or 3 days, physical therapy for 2 to 3 weeks, and then home exercises, which I'd like you to continue for at least 3 or 4 months, and ideally ongoing. The process is guided through physical therapy, and there's a relatively rapid recovery after a partial meniscectomy relative to the recovery after a meniscal repair. In terms of post-op visit, you'll be seen about 8 to 11 days post-operatively for a wound check and suture removal. And from a work perspective, typically people are back to work at 2 to 3 weeks. This, of course, depends on associated findings at surgery, the specifics of your meniscal tear, whether there's any associated arthritis, and the nature of your work, as well as your response to surgery. Patients will have a varied response to the same procedure. The main indication for meniscal repair or partial meniscectomy with trimming of the torn part of the meniscus is for relief of pain. And when the joint is well aligned, when the joint is stable and no significant associated arthritis, but an isolated meniscal tear, the results of arthroscopic treatment of the meniscal repair are excellent, with high satisfaction and high pain relief. If there is arthritic change or malalignment, such as varus, where there's increased forces through that compartment, there may be residual symptoms. The extent of arthritis can be evaluated at the time of surgery so that we have a better understanding of what to expect post-operatively. If there is moderate arthritic change, there may be residual symptoms, and these could be addressed with the addition of a lubricant. This is called hyaluronate. The trade name of the lubricant that we use is called Euflexa, but it is a high molecular weight, high viscosity lubricant that is used for the treatment of pain secondary to arthritis, so that if there's residual symptoms from the arthritis, it may be necessary to consider adding the viscosupplementation. Now, unfortunately, the lubricant does not work well in the face of a meniscal tear. So we address the meniscal tear and only use the lubricant if there are residual arthritic symptoms. Arthroscopic partial meniscectomy and meniscal repair are among the most common orthopedic procedures that we do and have high patient satisfaction. I'm going to show you the video of potential risks and complications, and then I'd like to review with you this discussion and answer any additional questions that you may have.